Hello, my name is Laura Adang. I'm a child neurologist at the Children's Hospital of Philadelphia. It is my pleasure today to talk to you about Metachromatic Leukodystrophy, or MLD. I'd like to first thank Maria Kafalis and her family for allowing me to share images from their beautiful book, Loeys Disease. Loeys Disease helps to guide families, and in particular siblings, through the new diagnosis of leukodystrophies. They have a new book, Bev and Lil, written by Maria's oldest daughter as well. I'd like to disclose that I'm a consultant to Orchard Therapeutics. Today we will talk about metachromatic leukodystrophy, focusing in on how to diagnose it, the subtypes of disease, which include late infantile, juvenile, and adult form, the genotype-phenotype correlation, the natural history of disease, treatment options and therapeutic trials, as well as the family support organizations. Metachromatic leukodystrophy is an autosomal recessive lysosomal storage disorder caused by deficient activity of aryl sulfatase A, which is a lysosomal enzyme that helps to break down sulfatides. Sulfatides, when ARSA is not fully active, begin to accumulate in the brain, the peripheral nervous system, and even the gallbladder. Because MLD is a disorder of enzyme deficiency, the mainstay for diagnostic testing is the ARSA enzymatic activity, which is typically measured through a lysosomal enzyme panel. I consider a companion test to be urinary sulfatides. In metachromatic leukodystrophy, the enzyme activity is low, and urinary sulfatides, which are the normal target for ARSA activity, become increased. The ARSA sequencing can be helpful in prognosticating and also understanding which subtype of MLD a child may have. This is because there's a reasonably strong genotype-phenotype correlation among the MLD population. Although this is not true for combinations of alleles, as it is unclear how they combinatorially affect each other. On the differential for metachromatic leukodystrophy is a companion disorder called Saposin B deficiency. In this disorder, children look identical to classic MLD, typically with the late infantile form, although the juvenile and adult forms have been described in case reports before. ARSA activity is normal in prosaponin deficiency, but urinary sulfatides are still elevated. In multiple sulfatase deficiency, children can have low levels of ARSA activity plus elevated urinary sulfatides. And this becomes increasingly difficult to determine whether a child has MSD or MLD. In multiple sulfatase deficiency, all 17 cellular sulfatases are affected and unable to be fully activated, and therefore oftentimes in MSD, children have other symptoms of companion disorders also caused by sulfatases, such as severe ichthyosis or scaling of the skin, or features of the 5 MPS disorders that are also caused by sulfatases. I would like to also have you caution to look for pseudodeficiency alleles. Pseudodeficiency alleles are found within the normal unaffected population at reasonably high carrier rates, and they result in a low in vitro ARSA enzymatic activity. The impact of pseudodeficiency alleles when in combination with pathogenic alleles is uncertain, but alone the pseudodeficiency alleles do not appear to cause disease state. The way we diagnose MLD will be changing in the coming years. Michael Gelb's group at the University of Washington has been able to demonstrate that dried blood spots can be used to measure aryl sulfatase activity. This is exciting because now we can potentially use this technology to identify children earlier and earlier and potentially offer therapeutic options. The MLD Foundation has been leading a lot of the patient advocacy group efforts towards adding MLD to the newborn screen in the coming years. Melissa Wasserstein's group this fall will be including MLD within their pilot study of New York State. This is exciting, and I think will lay the foundation for the advocacy group's efforts and our efforts in adding MLD to newborn screening. Our understanding of MLD is that it is a spectrum disorder divided into various subtypes. The youngest children have the late infantile form, in the middle are the juveniles, and the oldest people affected by MLD at the time of onset are designated as the adult form of disease. In the late infantile group, most people put the cutoff at 4 years of age, so children that begin to have symptoms before 4 years, although some groups do limit this to those that have presented under 2.5 years of age. Most children with the late infantile form of disease have very early motor symptoms and a rapid progression of first loss of motor skills, followed by a loss of cognitive skills. In the juvenile form, these children present between 4 and 16 years of age and can have quite a variable course with a combination of both motor and or cognitive symptoms. And the adult form is later onset, so anything that begins after 16 years of age. These young adults have early cognitive symptoms and actually can have a much more chronic course with minimal changes over many years. Within our natural history study, we're following the retrospective medical records for 173 individuals who are currently enrolled in our study. And we found that the majority of individuals enrolled in our larger study presented before the age of 2 years, which would fit with what is published in the literature, with late infantile being the most common form. In late infantile MLD, it can be difficult to recognize early in the course. Classically, there's a regression of walking skills between 18 and 24 months of age, but in practicality, this actually can be quite different. Children can have an isolated developmental delay beginning around 6 months of age. Some children never even reach the ability to walk, who ultimately are diagnosed with MLD. It can present as an isolated esotropia or nystagmus, and these subtle isolated symptoms can persist for many months before the more classic symptoms of motor regression occur. MLD can present as an isolated cranial neuropathy, and then similarly, it also can have a CIDP-like presentation. In many children with the late infantile form, the first manifestation of disease is the peripheral nervous system involvement. And so children can have a foot drop, and on EMG nerve conduction studies can be consistent with a CIDP-like presentation. And so I would caution young children diagnosed with a CIDP-like presentation and a demyelinating peripheral neuropathy, MLD should be considered in the differential. Once children lose independent ambulation, the motor and then cognitive progression can be quite rapid. Although I'd like to point out the MRI can be subtle or even normal very early in the stage of disease. And so in children, for example, with an isolated cranial neuropathy or esotropia, those first MRI images can be normal or near normal. They can show isolated nerve root enhancement. So I would urge caution with diagnosing a new onset esotropia or cranial nerve involvement in a young child. MLD should be on your differential and should be considered. There are some unique challenges to late infantile MLD, one of which is a quite pronounced early irritability. So similar to what we see in infancy with Krabbe, the young child with MLD can be profoundly irritable. There also can be significant feeding difficulties that are disproportionate to the degree of neurologic involvement. And later in the disease, spasticity and tone management should be a major target of supportive care. In the juvenile form of disease, it can be divided into two groups, the early juvenile and late juvenile. In the younger children, they oftentimes have motor symptoms more similar to the late infantile form. And the older young adults can have a much more chronic or personality changes similar to the adult form. Within the juvenile spectrum of MLD, there's quite a lot of heterogeneity, with up to 13% of young adults having actually a completely stable motor course for more than 20 years. And if you rate the neurologic gross motor function on a scale called the Gross Motor Function Classification Scale, or the GMFC-MLD, there's pronounced variability at the age at entry into a certain level within the juvenile MLD group. It's not as predictable as the late infantile form. This heterogeneity of juvenile MLD has been reported across multiple research groups. In the juvenile MLD group, I'd like to point out that there should be special attention to academic performance, behavioral and mood issues, as well as gait instability. New onset personality changes or academic decline in the middle school age range should be strongly considered as a subtle form of MLD, and it's key to identify individuals affected by MLD early in the course. The most difficult form to identify can oftentimes be the adult onset form of a leukodystrophy, and this is no different for metachromatic leukodystrophy. In the adult form, there can be very subtle subacute and chronic cognitive and personality changes. These can be problems in school or job performance, emotional lability, or frank psychosis. We suspect that many adult onset forms of leukodystrophy are underdiagnosed. There was a fascinating study several years ago that looked at atypical MRIs within adult multiple sclerosis centers in Europe. They identified 154 MRIs that did not look consistent with a known acquired demyelinating disease such as multiple sclerosis. And then they categorized the MRIs of these adults into 3 different categories: clear vascular changes, cavitary changes, or other. And within the other category, they sent enzymatic testing as well as molecular testing. And they identified a cause in 54% of those individuals. 11 were adrenal leukodystrophy, 5 were cerebrotendinous xanthomatosis, 3 were Krabbe, and 2 were leukodystrophies. That's a significant number of adults that were being followed in a multiple sclerosis center who ultimately ended up having a leukodystrophy diagnosis. And so I would urge consideration of biochemical or molecular testing for individuals with atypical MRIs and atypical neurologic courses that are followed within our white matter clinics more broadly. It's important to note that when we do identify a molecular cause for metachromatic leukodystrophy, there's actually a reasonably good genotype-phenotype correlation for the late infantile form. And so if you look at the age of onset for individuals with late infantile MLD, which is shown in the box and whisker plot, and we compare sibling pairs as shown by connected red dots, there's a very homogeneous distribution for age at onset. In the juvenile group, this is not true. Both within the juvenile group, there's a broad spread of when individuals are presenting, but even within a family, again, the dots connected by the red lines, you can see that there's a lot of difference between individuals within the same family and when they begin to have symptoms of disease. That spread is also true when you look at the change of the gross motor symptoms and you compare the late infantile to the juvenile forms of disease. On the left is work by the German Leukodystrophy group, and they looked at the age at entry. Children had different levels on a gross motor scale, again that GMFC MLD level. At the top are shown individuals that are age at when they entered the independently ambulatory phase, or level 1, compared to when they entered level 2, which is dependent ambulatory, level 5, which is head control only, and level 6, which is individuals that are non-ambulatory and do not have head control. Within the late infantile group, which are the box plots on the left of the plot, you can see there's a very narrow window in which individuals are entering into each level, suggestive that there's a very narrow window for progression within this late infantile form. But there's a huge level of variability within the juveniles, which is shown in the shaded box plots on the right. And you can see it's difficult to predict when an individual is going to be entering into the next level of motor function within the juvenile MLD. When we look at the time from disease onset to loss of all mobility, which again is GMFC MLD level 5 or 6, within our unpublished cohort of individuals, you can see those that present under the age of 2.5 years, which is shown in light blue, they have a very rapid progression and loss of mobility function. And the older you get, the slower that loss occurs, and the less predictable too. And so it becomes important to understand, as we're counseling families, which form of the disease they have. One of the key reasons is the importance in therapeutic advances that are happening in MLD. Currently, the mainstay of what we have to offer is hematopoietic stem cell transplant or mesenchymal stem cell transplant. The data behind MLD transplant, however, is not as robust as one would hope, particularly true for the juvenile form. And because of this, there's been great effort in recent years at developing more advanced therapeutic options targeting specifically the loss of the ARSA activity. One is using an autologous stem cell transplant-based therapy, using this gene therapy to replace the missing enzyme. These studies are actively ongoing in Italy. They do not have any US-based sites at this moment. The other therapeutic trial that is active right now is an enzyme replacement therapy where children receive an indwelling catheter and receive an intrathecal enzyme replacement infusion every single week. The results from that study are ongoing and have not yet been released. I would like to highlight the important family organizations that can help to support families affected by MLD. These include the Calliope Joy Foundation and Cure MLD, the MLD Foundation, the United Leukodystrophy Foundation, Bethany's Hope Foundation, Chloe's Fight, and Hunter's Hope, among other wonderful organizations that are out there. So in conclusion, MLD is a spectrum disorder. It is currently divided into 3 different categories based on age at onset, with the late infantile form, the juvenile form, and the adult onset form, but it actually is a spectrum disorder with a variable age of onset, a blending of motor and cognitive symptoms, and a blending of peripheral and central nervous system symptoms. It can be particularly difficult to diagnose early in the course, as it can be subtle, and subtle for months before it enters into a phase where children progress as more classic for MLD. I would caution special attention to any child that has a new onset peripheral neuropathy, cranial neuropathy, or there are concerns about motor development that began later in childhood. The course of MLD is particularly well understood for the late infantile form, but further research is needed into better understanding how children are progressing and
and why they progress at different rates within the juvenile cohort. There are exciting diagnostic and treatment options on the near horizon for MLD. So I urge you to keep your eye open for these developments as our understanding and our options for MLD are rapidly changing. I'd like to, in conclusion, acknowledge the CHOP MLD research team and the Tübingen group, the Royal Children's Hospital team, and the McGill University team, who are among many of our important and wonderful collaborators in this field. And I'd also like to thank Marika Fallis of the Calliope Joy Foundation for allowing me to use the beautiful images from her books. Thank you. I'd be happy to entertain any questions now.
Thank you, Dr. Adang. We do have a question here on the board. So the question is, what do you think is the cause for the early sudden onset of dystropia?
Yeah, I think that that's a really good question. And I see the second half of your question asks about if fever or illness can precipitate. It hasn't been rigorously studied, but certainly I have seen through both children I care for as well as within our natural history study, there can be a triggering event. I have seen it across several different leukodystrophies where really that tipping point is brought on by a fever illness. I've also seen the esotropia be intermittent, which really looks very convincing for a more traditional, less ominous form of esotropia. Many of the children that I have met have actually gone to surgery to get the intermittent esotropia repaired. Of course, it is ultimately progressive. So what do I think is causing the esotropia? I think that it is having a threshold of sufficient myelination to do a function. I find many kids have worsening symptoms around times of fatigue and infection and illness, such like that.